everybody. Thanks for joining us today. My name is Lylan Ferris, and I'm the Senior Staff Physician for Doctors Data. Today's webinar by Dr. Kalish will be followed by a live Q&A session. So during the lecture, feel free to type your questions into the Q&A box, and we'll answer as many as we can at the end of the lecture. A recording of this webinar is going to be emailed to everyone and after the fact, and a link to download the slides has already been posted in the chat box, and we'll continue to post it throughout the webinar. I did want to let you know that in addition to this webinar, Dr. Kalish is also offering a 4-week boot camp with live calls to focus on interpreting doctors' data adrenal labs. This includes salivary testing and the new HUMAP tests. He's going to give you some more information about this boot camp during this lecture, and we'll also be emailing everybody a special discount code as well. So now I'm excited to introduce today's speaker, Dan Kalish. He is the founder of the Kalish Institute, an online training program dedicated to building functional medicine practices. In 2017, Dr. Kalish joined the practice implementation faculty at the Institute for Functional Medicine and also leads an online mentorship program in functional medicine that emphasizes clinical application and program design skills. Dr. Kalish received his BA in Physiology and Psychology from Antioch College and completed his chiropractic degree at Life West. He studied at the University of London and conducted research with biochemist Dr. Robin Monroe at Cambridge University. He's the author of 3 books and is a frequently requested speaker for integrative medicine conferences across the United States. Dr. Kalish, thanks for joining us today, and I will hand it over to you.
Yes, thank you so much again for sponsoring and putting this together. So we are excited to be talking today about hot flashes, night sweats, and insomnia, mood swings, things like that. Effective natural treatment options for perimenopausal women. So the first 10 years of my practice, the first decade, I focused almost exclusively on female hormone balancing. I mean, at least all my marketing and all the promotion that I did for my practice. And I found during that 10 years that in the scheme of functional medicine problems, this was the easiest thing to correct, given the amount of work that was involved on my part and on the patient's part versus the potential benefit. So in other words, huge amount of benefit, not a whole lot of work. So it's a wonderful practice builder. It's a wonderful niche to have. It's a great place to be if you have a chronic illness practice and you're really kind of a little bogged down emotionally and maybe a little burned out with so many difficult cases. You get quick responses. You change people's lives. I could count literally on the fingers of probably 2 hands, the number of women over 30 years for whom these programs haven't really worked at all. So you're very high success rate in terms of helping people. So anyways, for those of you that are doing this kind of work, you probably already know that. For those of you that are new to perimenopausal programs, I just want to encourage you, this is a really great niche. And there's a caveat though, which is that in order to have that dream come true and to have an easy go at it with these kinds of cases, you need to do the adrenal testing and correct adrenal problems and test the GI 360 and correct the gut. If you're not checking and testing the adrenals and you're not testing and correcting the gut, then you're going to have a lot of challenges with these cases. So it's an integrated problem, and it goes across lines to the stress response component and to the gut component. Okay. So here we are. This is me, Dan. Very glad to be here. And here we have what's coming up that was just mentioned. You get a 20% discount for being a doctor's data person for our upcoming boot camp, which is wonderfully featuring the doctor's data salivary and urinary hormone testing. So we're going to look at salivary adrenal hormones, and we're going to look at their HUMAP specifically in regards to the adrenal markers on there, not the entire test, but just the adrenal portion. So this is like a focused month of really diving into adrenal labs, both salivary and urinary, and seeing how all that works and what you can do in terms of program design. Very complementary to what we're talking about today. It's a 1-month class, and it starts April 6th, pretty soon. So you guys want to sign up? I think you would enjoy it. All right, and let's get to the topic at hand here. So perimenopause, hormone changes are inevitable. This is not necessarily a bad thing, right? It's just a person getting older. Progesterone levels are going to start to decline. The more stress that the person is under, the earlier and the more dramatically the progesterone levels will decline. Hence the benefit of doing the adrenal programs along with the female hormone balancing programs. Estrogen obviously is going to decline, but it's going to be a little more gradual for most women and maybe not quite as dramatically impacted by stress, but of course impacted by stress as well. And then you have this whole low progesterone estrogen dominance situation. So the researcher, physician, clinician, writer that developed that term, estrogen dominance, was a man named Dr. John Lee, Lee, and he wrote a book a long time ago called Progesterone. it was a little white book, and the cover it said progesterone, and that was the entire book. I have a copy of it still. It's really hard to find these now. So in 1992, I went to a conference on menopause, and Dr. Lee was a keynote speaker. And so I went up after he gave his talk and just basically glommed onto him. And so for my first 3 years in practice, every single female hormone case, I would call Dr. Lee on the phone. This is when we actually had phones. We didn't have smartphones. We just had phones. I would call Dr. Lee. He would pick up the phone and we would talk about the case. And then at the end of the conversation, which ranged from 10 minutes to maybe half an hour, he would say, sounds like she needs progesterone. Okay, thanks, Dr. Lee. So he was really wonderful to me. He spent a lot of time training me and was an amazing fellow. And he wrote a series of books called What Your Doctor May Not Tell You. What Your Doctor May Not Tell You About Menopause was the first big one. And those are still worthwhile reads today. I mean, they're old now, but hormones haven't changed a whole lot. So Dr. Lee really pioneered the use of topical progesterone. He started thinking about it in the 1970s. And then I met him in the early 1990s when he was already retired, but still going strong mentally. And that's when he started to write all his books, was after his retirement from practice. So this idea of estrogen dominance is that estrogen can become overly dominant, meaning that if progesterone levels drop and estrogen stays the same, you can have an imbalance between the effect of estrogen and progesterone. So you don't have to have high estrogen in order for estrogen to be dominant. Low progesterone nets you out the same problem as high estrogen would. Okay, and then of course there's xenoestrogens or chemical compounds that mimic the effects of estrogen. So if you have a lot of stress in your life and you're perimenopausal and your progesterone levels have declined a little bit more in ratio than your estrogen levels, you're going to end up with estrogen dominance. You add on to that the xenoestrogens, and all of a sudden the scales get tipped, right? And you can end up with a pretty serious hormone-related issue. The beauty of this particular problem is that there's only two hormones that we're talking about here, progesterone and estrogen, and that can only go up and down. There's not that many variables. It's not like trying to fix someone's mitochondria where you got 1,600 different things that can go wrong. So you're either going to raise up a hormone or lower one, and it's not that hard to do any of this. Once you do the labs, you can see exactly what's happening. Now, the symptoms for these problems can be dramatic. People can't sleep. People can't function because they have a migraine headache. People are having all kinds of fatigue and depression and mood-related problems. So the symptoms can be quite far-flung and quite dramatic, but the testing and the solutions are really, incredibly simple. So there's so many different options in this field. We have practitioners coming into my mentorship program all the time. They may be an acupuncturist and they have one way of looking at this. They may be a bioidentical HRT kind of doc, and they have a different way of looking at it. They may be a naturopath. So many different ways that you can do this that I'm just going to present a way today. And I'm not saying this is like the only or best way, but this is a really effective way to do it. And there's certainly, I don't know, it's one of these areas where there's so many different approaches. At some point, you kind of have to pick a lane and decide what you're going to do. There's a group of practitioners that believe that women it's best for women to keep menstruating their whole life. So not, age 50 menstruating, age 60 menstruating, age 70, age 80 menstruating. And so they give hormones in such a way to continue the cycle. That never made sense to me. So I'm just kind of putting that aside. I'm not against that. Like I'm not vehemently protesting people that do that program, that kind of a program, but I'm just saying we're not going to even talk about that because it doesn't make sense to me personally. What does make sense, a lot of sense, is to use the bioidentical or natural progesterone, and you can get it in a non-prescription form, in a topical form, and to use the lowest possible dose of a plant-based estrogen to alleviate these symptoms. I'm not necessarily advocating that a woman has to do this for her entire life. We're really talking about perimenopause and getting a woman through that transition, whenever it is, somewhere around ages 45 to 55. Whether then, it's a separate question really, whether then a woman who's in full menopause should take hormones every day the rest of her life. That's probably, we could talk about in the Q&A section if you want, but that's really a separate question. And women themselves and physicians, practitioners themselves all have different opinions about that. But for sure, we can agree that during perimenopause, when there's a lot of symptoms, we should be able to get symptomatic control, whether that's going to be a lifetime program or not. Okay. Pretty straightforward to do these programs. You can take the hormones throughout the month. Usually, you're going to stop for a 4 to 7 day period. That's sort of typical. Depending on her age and what your goals are, there may even be some perimenopausal women that do a 2-week on and 2-week off schedule of the hormones. Although I think most of these women will end up on a more consistent daily regimen with anywhere from 4 to 7 days off. There's different reasons why you might want to switch between those. But you want to make sure that you do it safely. That's the main point. So menopause defined as no periods for a year, and the hormones are obviously dropping. The significance of the drop of estrogen and progesterone will be magnified to the extent that there's an adrenal problem. So I had this patient, her name is Sharon. She was a patient when I was 30 years old, which was the first year I started my practice, and she was around 30 years old. And she had a whole bunch of young kids. And lo and behold, like 24 years later, Sharon contacts the office. I hadn't talked to her in a while. And her daughter needed a treatment, which was great because the kid was all grown up. And then Sharon's like on the phone, and she's like, well, I don't know. Something's really wrong. I'm really worried. I'm like, what's going on, Sharon? And she's like, I don't know. All my friends are having these problems, like hot flashes and night sweats, and their sex drive is no good, and their skin looks horrible, and they're just having all these horrible problems. And so, what's going on? I'm expecting some horrible things. She's like, nothing. I feel great. I don't have any perimenopausal symptoms. And I started laughing. I'm like, Sharon, don't you remember 20 years ago when we balanced out your hormones? This is the fruit of that labor, right? So in other words, she was worried because all of her female friends were having problems as they hit their 50s, and she was skating through. So if you balance out the adrenals and you keep them balanced, and you balance out the female hormones in a woman's 30s or 40s, then menopause is an absolute breeze. And I have patients now, I'm old enough to have patients that I've actually seen that. It's not just a theoretical thing. I've actually watched this happen to a whole demographic of my patients that have stuck with me all these years. So anyways, this stuff really works in the moment. And then if you have women who are younger, let's say in their 30s and 40s, and you want to avoid all this hullabaloo of perimenopause, then just get their adrenals and female hormones and gut fixed early in their 30s or 40s. And these kinds of problems that we're talking about today won't even occur, because these problems are a result of chronic stress, blood sugar regulation problems, inflammation in the gut, and all the usual things that we associate with any kind of a chronic health problem. Okay, so now there's a couple little things I just thought were worth pointing out, especially when we get to the labs. You're going to want to think about this, is that there's a 1 to 5 year window where hormones fluctuate prior to settling down to a fixed daily production. So I used to work at a lab company a long time ago, and we would do these month-long female hormone panels. And someone got the bright idea to do month-long female hormone panels on all these perimenopausal and menopausal women, which is a dumb idea because normally you would think you would do the month-long panels only on women that are still cycling. Okay, this is, I don't know, it's just someone's idea at the lab. So we did it. And what we found was that women would continue to cycle internally anywhere from 1 year to 7 years after the cessation of their period. So in other words, if your period stops and then you're, say, 52 years old, and then you fast forward a year, you could still be internally cycling, not enough cycling to create a menstrual cycle where you're bleeding, but still an internal fluctuation. And if you carry that on 2 years, 3 years, 4 years, as long as 5+ years, after menstruation stops, we were still seeing internal cycling. And so the reason why I bring this up is because that can make it a little difficult sometimes to get your dosing right. The closer that the woman is to menopause, the more her internal production may be changing a little bit. So the more that your program that works on a given day might not work on another day. And so if you're getting patient complaints where they're saying that this program is great, but there's a few days a month where it's still not working right, it may be that the internal fluctuation of her hormones is impacting your program. And I think the easiest way to resolve that is to just do what I said in the earlier slide, which is to keep the dosages as low as possible. And then if you need to, gradually titrate them up so that you're covering her on every day of the month, right? Even on a day when the hormones are naturally dropping a bit, you're still covering over that. And if you have the adrenal programs in place, then usually these kinds of problems of the programs working certain days of the month, but not other days of the month, usually will go away. Okay, the adrenals support programs will usually mitigate all that, right? For women, and usually when women are having the most symptoms is when their cycle is the most erratic. And so it's hard to know exactly in a situation like that, should you try to reset the cycle and do a 2 weeks on, 2 weeks off program to bring the cycle back and let it even out and then fade out? Or should you treat the woman as if she's in menopause, even though she's in perimenopause, and shut the cycle down? So that's always a big decision. And you guys have questions about that. I think most cases, you're going to have to decide that in the very beginning. Are we going to treat you as if you're menopausal and just give you a program that acknowledges that the hormone production is flat, or are we going to try to resuscitate the cycle and bring it down, bring it back? And that can vary too. On you can ask the women, like, what was the age when your mother went through menopause? Do you have any older sisters? If the woman's 47 and all the women in her family have gone through menopause in their mid or early 50s, then you may want to reset the cycle because it may be normal for her to have a cycle for a few more years. And the problem becomes that as women are more and more stressed and the cycle's impacted by stress hormones, they can basically prematurely go into menopause because of all the stress factors. And it may be that just correcting their gut and their adrenals and then a little bit of progesterone for 6 months might actually bring their cycle back. So she might continue to have a cycle from age 47 until 52 and then have it naturally decline. So in other words, we don't want to suppress a cycle that's not working well because of some stress or internal organ problem, like something wrong with the gut. As much as you can, you want to restore the normal health of the body and then see how the cycles are playing out at that point. Okay. Then we get this a lot in the mentorship class, and we had a OBGYN in the group recently that talked about this every few weeks in the class, which is just the preference for using progesterone. And I think that's something that's come into fashion now because estrogen's gotten a pretty bad name. And so there are certainly many practitioners out there that during the menopausal treatment years will primarily use progesterone and only use estrogen if they absolutely have to. And I guess I'm an advocate of that. I think that's a good idea. I mean, sometimes it's easier and faster to use progesterone and estrogen together, but I certainly understand people that have a caution, that feel a lot of caution around the idea of using any kind of estrogen at all. Okay. And now, this is just an off-the-cuff comment, but it's so important, I thought it was worth putting it in the notes here as a slide. If you have a non-responsive patient, and non-responsive to me means you're a month or two into this program and it's really not working very well, and you're getting a little frustrated and she's getting a little frustrated, then I would seriously consider checking neurotransmitters. I'm assuming that the adrenal program is already running. So an adrenal program would be required, I would say, to balance any female hormones issue. But if the adrenal and the female hormone program is not coalescing and you're not getting results in your first month or two, then think about dopamine. And you often will find that a simple dopamine correction, some tyrosine, maybe some Acuna, will kind of launch the female hormone program in a much better way. The adrenal programs, again, I would say I've always done with the female hormones, so I think that's almost like a requirement, along with checking the gut. Dopamine, I wouldn't jump into it unless you're a month or two into the program and you really feel it's like not working and you think something's being missed here. Dopamine does have a lot of regulatory control mechanisms over the sex hormones, so something to think about. And then there's, I guess, different categories, really, if you want to think about it that way. So the majority of what I've done is with patients that are coming in and they're highly symptomatic, and they're usually between ages 45 and 55. There's going to be there's not a lot of women that I've worked with that are in their 60s or 70s that are still complaining about female hormone symptoms. I'm sure that occurs, but maybe that's just not a demographic that I attract. Or I think by that time, a lot of these problems have sort of sorted themselves out on their own. However, there may be some reasons for a woman who's been in menopause for a long period of time and doesn't have a lot of immediate symptoms that are just like I can't sleep at night, or my sex drive is completely gone, and those kinds of things. There may still be some reasons for using progesterone and estrogen more almost like as a wellness product or a longevity product. And I have a fair number of women who have been in my practice for over 20 years that still take really, really, really small amounts of progesterone and estrogen every day, even though they're far past that perimenopausal phase where there's a lot of chaos. And I think if you're doing yearly testing and the levels are very low, that this is a reasonable approach. And these are women who typically will try periodically in the beginning to get off the hormone support and just find that they feel a lot better when they take them. And so I don't advocate for this, but if you end up in this place, I think you can handle it safely. In other words, I don't advocate for every woman who's age 50 to take hormones her whole life, but it definitely certainly happens, and you can do it safely, I think, with the bioidenticals. Now, in terms of ordering tests, which tests to order, how do you order them? Oh my gosh, so complicated. So if she's having a regular cycle that you can identify, then you typically want to do the test around days 18 to 23, somewhere in that range. But many of these women are not having a regular cycle. And so they may not have had a cycle for 3 months, or they may not have cycle for a year, or maybe they have a cycle every other month, or it could be somewhat chaotic. They may not know what their day one is. If that's the case, then I just, simple instructions, you just give the kit to her and say, normally this lab test is performed, in the second half of the cycle, right after you ovulate. And so even though it's not clear what day that is, let's just have you do it, this test, as close as you can get to that, and have them go at it, right? Because otherwise, if you wait, it can take months and months, or 6 months or a year to even get a test done. So I think it's better to get some test data in the beginning than no test data, and getting it as close to that point of the cycle. Now, if she's in full-blown menopause, obviously doesn't matter because the levels are going to be much more consistent and flat. And then in terms of retesting, usually we retest in the beginning at around the 6-month mark, 3 to 6 month mark, make sure the program's going well. And then for long-term patients, usually we test or retest around once a year. And then how long should you expect for patients to experience relief? I mean, 3 or 4 weeks, really. This should happen quickly, which is the wonder and joy of all this. How long do the programs go on? I don't know, not forever, right? We just said not forever. So 6 months to a year, and then trying to lower the dosages and see if you can get away with getting off the program. Maybe 1 to 2 years max, something like that. How often do you want to follow up? So in the beginning, I usually check with patients every month, maybe every 4 to 6 weeks, until we know the program's working extremely well. And then we go to like an every 3 month, and then every 6 months. And then for a large number of the hormone patients that I've worked with, we just have a regular yearly checkup, and whether they're taking anything or not, just to make sure that everything's on track. I think the yearly checkup with the lab test is sort of the honest part of being in practice, really. These are people that you've corrected whatever their original problems were, but now you've just got, I mean, they're not friends. I was going to say they're not a friend, but you've got like a regular patient. They're not coming and complaining about anything dramatic. They're not expecting you to save their life in any way. The stakes are really low. You're more like building a long-term relationship with these people. And you're just like, how are you doing this year, Susie? Let's look at your labs. How's your diet been? It's more of a coaching relationship, or I don't know how to put it, but it's different than the doctor-patient thing because it's not this person in a desperate situation and their Lyme disease has ruined their life and now they can't think because they have this neuropsychiatric problem. It's not that kind of stuff. It's more like relationship building and having a connection with person as like their health advisor or like their health consultant, something like that. And I really like that role a lot. So I have a lot of patients where I do these once a year checkups with. I had 2 or 3 this week. And it's really nice. It's a nice kind of connection to have to somebody, and you're a kind of an institutional part of their health plan, and they listen to what you say, and you'll put them on all these great supplements every year, and you'll check them again in a year. And I think that that's sort of, for me, where I want all my ideal patients to move towards, out of this symptomatic back and forth kind of nightmare thing that we have to do in the beginning, and to more of a wellness program and a yearly checkup. But I can't emphasize enough, the yearly checkup has to include a lab. And it doesn't matter which test it is. You could do a GI 360 every year if they have a GI problem in the past. I mean, I do a lot of hormone testing, so the hormone testing once a year makes a lot of sense. But you want something concrete that you can talk to them about. And like having a yearly follow-up test for all your maintenance patients, I think is really important. And then how often do these programs work or not work? I get kind of surprised if a basic adrenal GI female hormone program is not working, there's something else going on. So I'd say 80, 90% of the time, you should be able to relieve most of the symptoms with this kind of stuff. And if that's not happening, then there's something extraordinary going on. Maybe some genetic issue or some hidden underlying infection or something pretty serious that's been missed. And the most common reasons programs don't work is people don't listen to what we say, and the lifestyle changes are not being followed. And people don't tell you about that in the beginning. They don't tell you that they're drinking, a bottle of wine every night. Even though you asked them about alcohol, they kind of lie. They didn't tell you that. Or they didn't tell you that, well, this happened a few years ago. So this is a horrible story, but it's a true story. This woman's son was murdered. Her son had been homeless for a long time. He got his life together, got his own apartment. It's like maybe in his mid or late 20s. And then he let this other homeless person that he used to know stay at his place, and he was stabbed to death in the middle of the night in front of his daughter. I mean, she didn't tell me that. Okay. And so she had this massive amount of stress from the death of her son in such a violent way. And she's raising the grandchild now herself. So, I mean, a stress and hormone related program may not work in a situation like that, right? Where the person's just under an incomprehensible amount of pressure and stress all the time. So if these programs aren't working, and then you just want to dig in and find out why and start to talk to people about what's going on. Are they really an alcoholic? Was there some kind of major trauma in their life that they didn't tell you about? And are you going to get them grief counseling? Are you, like I did for the woman with the son that died, are you going to get them, alcohol and drug rehabilitation counseling, food addiction counseling, whatever it may be? So if these hormone programs aren't working, it's usually because there's some huge underlying stressor that you need to, figure out with that person. So there's some guidelines here, and we're going to look at labs in a second, okay? There's some guidelines here on testing, and these questions get asked a lot. And so Doctors Data has these. I would suggest that you read through them a couple of times because it'll really help you in your interactions with patients. Maybe post it on your wall or something, or put it somewhere that's easily accessible, okay? Because these questions come up a lot, and you kind of have to memorize most of these things. Or you could even just print these out somewhere and leave them in your desk drawer, or take a snapshot and put it on your laptop, on your desktop, on your laptop, or something like that. Somewhere where it's easily available. So you have all these at your fingertips, okay? These are all the details you're going to need. And then in terms of protocols, so diet and lifestyle, obviously, adrenal support sometimes is enough. You may get significant enough relief from female hormone problems with an adrenal program that you can just stop right there. Herbal blends and nutrient therapy, certainly we do that with everybody. And then bioidentical hormones. And you can get them all in a non-prescription form. If you're a prescribing practitioner, if you're a nurse practitioner, a medical doctor, or osteopath, you can prescribe them as well. I find patients really like the plant-based natural stuff. They like the concept of it. They kind of like that it's not a prescription, even though it's the same hormone. I don't know. It just sort of takes the whole thing down a notch, in a sense. So anyways, people like the idea that it's from a plant, and we want to endorse, all potential effects Even if it's a placebo effect or if it's based on belief, in some ways, placebo effects are probably the most important effects because what we believe kind of creates these different situations. And if someone believes that natural plant-based products are better and they're taking one and it works, more power to them. There are, and all the companies that we work with have combination and then single ingredient products for hormone balancing. Everything from black cohosh to Vitex. And I prefer to use the topical progesterone and estrogen. Why is that? I don't know. It just seems more direct and obvious and easier to control. But I do occasionally, maybe a third of the time or something like that, use these other types of products. Or there's some situations where you may want to use a maca derived product first. Some women don't want to take hormones at all, even a plant-based hormone, even a bioidentical plant-based one. So that's fine. So we have these, in your back pocket as well to use as potential treatment options. And then there's complementary things that can go along with a female hormone program. And again, if you're using the progesterone and estrogen topicals properly, you usually don't need to do too much more, except for sometimes you may need extra melatonin. That can definitely happen. Sometimes you need, as I mentioned earlier, some support for neurotransmitters like 5-HTP or tyrosine. Sometimes there may be just some calming product like theanine or inositol or magnesium at nighttime can help. And so I'm not against that. Anything that gets people sleeping and gets their mood to improve, for sure, we can add in additional therapies. But I would always say that the big dynamic movers of the symptoms are going to be the progesterone and estrogen and what you do with that. Okay. So bioidentical hormones, I got back to Dr. John Lee, my first teacher, his book Progesterone, on the cover of that white little book, it had a molecule of progesterone. I think he sold like 15 copies of it, but he eventually became quite well known as a writer later on in his life. So it's the identical. So we're talking about bioidentical or plant-based hormones. They're made from the progesterone is made from a wild yam plant called Dioscorea, but it's not like a wild yam like you eat for Thanksgiving. It's like a gourd. It's like this kind of roundish looking gourd type structure. And turns out that that plant has a molecule in it which can easily be converted into actual progesterone. So when we talk about topical non-prescription bioidenticals, the ones that we use or I recommend people use actually have real progesterone in it. It's the real hormone. It's not a wild yam derived blah blah. It's the actual progesterone itself and can be quite effective. And of course, there's synthetic progesterones, which I can only think bad thoughts about. I've never really seen those help anybody, and they can cause a lot of side effects and problems. So in a world where I'm trying to not be judgmental, I am pretty judgmental against synthetic progesterone. I don't see why you'd ever want to use that. There may be some rare medical application I don't know about, but why not just use the bioidentical, whether it's prescription bioidentical or the over-the-counter stuff that you can get in the topical forms? I think it's just quite a huge advantage over a synthetic hormone, and I don't see any need that you'd ever want to stray from that idea. So there's all kinds of different delivery routes. There's sublingual, transdermal, there's patches, there's suppositories, gels, the list goes on. And there's different kinds of absorption methods, right? Lymphatic absorption and getting it through the skin and all these different things. There's problems with progesterone creams in terms of quality. So you have to make sure you're getting obviously good quality products and that you're able to get the dosing quite specific. I prefer the liquids that are in drops because it's very easy to measure what a drop is, that's not complicated. Pretty much everyone on the planet, no one's ever said, what do you mean by a drop? You know what I mean? But if you're trying to get a cream that's a certain amount of it's just harder to quantify exactly how much you want them to take. But 5 drops twice a day, that's a really clear instruction, and it's pretty much impossible to mess that up. So I'm a really strong proponent of the liquids that are in a drop form, and they obviously many of them can be applied topically too. So that's another thing. And then in terms of non-prescription plant-based estrogen and progesterone, there's several different brands, again, that have topical estrogen. Sometimes they combine it with the progesterone. So there's some products where the estrogen and progesterone are together in one combined product. And then there are other companies that'll have separate progesterone and separate estrogen. Depending on what your goals are there. The combination products can be really handy for some women because they don't have to have 2 bottles on a table every day, right? They just have 1 bottle. But of course, the limitation on the combined products is that you're stuck with that fixed ratio. Whatever's in that product is the amount that they're going to be taking, and there's no way around that, you know? And then, of course, there are the prescriptions, Triest and Biest. And we've had tons of bioidentical hormone prescribing docs in the mentorship. I've talked to many of them, and I was going to say, but not as a joke, some of my best friends prescribe these hormones, and they do. Some of my closest friends now are medical docs that use these hormones all the time. I'm a chiropractor by training, so I've never prescribed any of these, but I'm certainly not against them. I really like the natural over-the-counter stuff. Maybe that's my own, personal thing because of my background and not being able to prescribe. But these are all available too for those of you that want to do that. But again, as I said, I think patients kind of like the whole it's not a prescription, it's a natural product kind of thing. You can get progesterone in a bioidentical form by prescription, but of course it's going to be typically in a capsule. And there's some arguments for and against that. I mean, I think the main argument for the topicals, liquids and sublinguals is that the hormone gets into the bloodstream directly, circulates throughout the body, and as that's happening, hits all the different cells of your body, and then eventually your liver starts to filter it out and breaks it down. Whereas when you take it in a capsule form and you swallow it, obviously the hormone first goes to your digestive tract, then gets absorbed, then immediately goes to your liver before it gets into your general circulation. So your liver has to metabolize it or break it down, and then what's left over ends up in the bloodstream. So I think the skin as a route, or the sublingual liquids, going through the mouth as a route, is seen as more direct, going right into the bloodstream, bypassing the gut and the liver as a more guaranteed way of absorbing. You can also maybe be a little more specific about the amount that you're giving the person, because you don't have to worry about all these metabolites and what's being broken down into what, and again, there's this cycling dosing option. Now, for some of the women in this age group, let's say 45 to 55, they will be having a menstrual cycle that's slowing down prematurely due to stress. And when you put them on that adrenal program, oftentimes their period comes back just from the adrenal program. So clearly, if that's the case, they had a stress-induced kind of early onset menopause. So you don't want to suppress. If the woman's 47, you don't want to suppress her cycle at age 47 when naturally, given the stressful circumstances are gone, she might not start to enter menopause for 5 years. And so you have to be kind of on the lookout for that. And there's certain women that you're going to want to do this cyclic dosing, 2 weeks on, 2 weeks off. And then other women, you're going to do the opposite, where you're going to, pick a day and say, we're going to start on a daily program. We're not going to cycle it, except for we may take you off for a few days a month. So quick summary before we look at some labs. Lots of testing options available. And the protocols should always include adrenal programs. You may want to also have herbs that modulate function. I feel like the progesterone and estrogen are the most direct and efficient way to fix these things. The fewest number of products and the fastest results, personally, has been my experience. But if you have a patient that's willing to drag things out a little bit longer and take a few more extra products, then the herbal modulators can work super well also. So you have a bunch of options there. And for those of you that joined us late, 20% discount on the upcoming boot camp. So we have a Getting Started Interpreting Doctors' Data Adrenal Labs, both salivary and HUMAP, starting on April the 6th. It's a 1-month class. It's kind of I created a whole new curriculum for this, by the way. This is one I've been teaching adrenal stuff since 1995, but I just redid all my slides. I got pretty excited about this. I want to focus on the HUMAP and its benefits and how that fits in. And then I really want to get into the HPA axis and the salivary, so you guys understand exactly how you can test and correct the HPA axis and understand how profound that can be for treatments. And that can help with thyroid problems and female hormone problems and brain problems, so many different things that you can do when you start to correct the HPA axis. Okay, so it's a 1-month class, and it's really focused on interpreting labs. It's more of like a workshop. There's a series of lectures, and then there are live calls where we're going to review labs and design programs together. Okay, and let's see. Let's pull up some tests right now. And I want to leave tons of time for questions because I'm sure there's going to be some. I mean, okay, let's forget the adrenal thing for now. Take the boot camp for the adrenals. So we're going to skip over that. Let's just look at the female hormone part. I mean, if you've ever looked at like an amino acid, organic acid, fatty acid profile or something like that, and you look like you're thinking, wow, there's 146 markers on this test, and I don't even know how to pronounce most of them. You know, that's lab interpretation that takes decades to learn. This is so straightforward. You've got estrogen, high, low, normal, progesterone, high, low, normal. And let's even forget about all these other things, just those two variables. That's it. Progesterone's low, you give progesterone. Estrogen's low, you give estrogen if you need to. Some doctors, remember I said, even in the face of low estrogen, would start with progesterone and see if that's enough. Totally legitimate to do that. So with a lab like this, you could just start with progesterone, see what the response is like, or you could do progesterone and estrogen together. And then monitor them. How often? In the beginning, maybe in 3 months, then after a while, every 6 months, then eventually moving to once a year. But you want to make sure the program's working and you're keeping the person in the supplementation range, right? And so really the only decision you need to make is, should I use progesterone by itself or progesterone and estrogen together? If you're in a rush and the patient's in a rush, just use them both. Extremely straightforward. I don't know. I'm just amazed as I look at this how easy it is. It didn't seem easy 30 years ago. But there's just very few decisions you need to make. You just need to see where the hormone is, give the product, and then retest them and watch people get better. So again, in the world of labs, this is, you know, let's just say very straightforward. Now that was a salivary panel. Now here's a HUMAP. And the HUMAP also has, right here, you see on the front page, progesterone and estrogen levels too. Okay. And we should all know this, but there's 3 forms of estrogen: estradiol, estrone, estriol. I said those kind of backwards. It's really estrone is E1, estradiol is E2, and estriol is E3. So estradiol right there is E2, which they're measuring. Estriol is E3. And then the different forms of progesterone up here you can see. And here's your estrone and progesterone. Okay. And so this all appears too on this test. If you want to capture all the metabolites, some of you are going to want to get into this. And here you can, and this is, of course, the HUMAP is from a urine sample, whereas the first one I showed is salivary. So here you can see progesterone. It's the same basic conceptual framework, though. If it's low, you support it. If it's not, you leave it alone. And then you can look at the different forms of estrogen. I find these a little overwhelming, you know, because there's so much data on them. But some of you will prefer that, to have all that extra information. And some of you may prefer this sort of simple test like this. If you're just starting out and in your first couple years of doing this, I would suggest, you know, starting at least, let's say your first 10 labs with a simple one. So you get your feet under you and you kind of feel a little confident and you watch a bunch of people get better. And then if you want to escalate, for sure, you can go to the HUMAP and look at all the metabolites and get all that extra data. That is so interesting. Let's see, let's look at one more, okay? And we're ignoring the adrenals. But I said like at least 10 times that they're important. Wow, look at that. They can't really ignore that. That's not good. We get cases like this all the time. I can't believe people like this are functioning. Anyways, look at the cortisol, just low, 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 and DHEA low. So this person has clearly got more than just a female hormone problem. I mean, if you don't correct this part, you're not going to get too far, all right? And then let's see what happened to the female hormones here. Okay, so estradiol is normal, within normal range, and then the progesterone is low. So now you have even less of a decision to make. really don't have any decision. You just give the progesterone. You don't even need to give the estrogen. There's no need to. So if you put this person on a good adrenal program with DHEA and pregnenolone and all the other things required for the adrenals, and then gave them additional progesterone, you have it made. So then there's going to be one important consideration, I guess you'd say, for each one of these people. And you're going to have to think this one through on a case-by-case basis. And that consideration is going to be, are you going to give the progesterone 2 weeks on and 2 weeks off, or are you going to give it every day of the cycle with maybe a few day break? And so, again, you have to think through, are you trying to shut the, is the cycle already shut down on its own or almost shut down on its own? Or is the cycle prematurely getting erratic and shut down because of all the stress? So if you see a lab like this, a 49-year-old that has adrenal hormone production that looks this bad, right? And then you realize that progesterone and cortisol are linked, and DHEA and estrogen are linked, or these connections with these hormones. And when cortisol and DHEA are this suppressed, that's going to have an urgent and immediate impact on progesterone and estrogen. And so in a way, you maybe can't totally accurately interpret what this page means on progesterone and estrogen until this page is improved. So with this person, you would put them on an adrenal program, DHEA, pregnenolone, licorice root, blood sugar support, adaptogenic herbs, maybe some glandules even, vitamin C, pantothenic acid, all that stuff. Boost up the adrenals for a few months. Maybe give them the progesterone in the beginning also. Why not? They're low in it. And then start to see what's happening in terms of, is their cycle going to come back? Did they just miss 1 or 2 cycles and now it's back to an every month thing again because it was prematurely fading out due to the adrenal problem? Or maybe her mother went through menopause when she was 49 and so did her older sister, and it's normal in this family for women at age 49 to have their period stop, in which case you don't want to do, a resetting of the cyclical program. So that is a big decision to make. And I think, you just have to take that on a case-by-case basis. One thing you can do, which is kind of obvious, is ask the woman, do you think we should reset your cycle? Or are you happy that you're no longer having a cycle? And a lot of times women have an immediate and strong opinion about that. And they'll look at you and go, are you crazy? Yeah, I don't want to have my cycle come back. Or they'll look at you and go, are you crazy? Yeah, I want to keep cycling. So sometimes you could even just let the patient determine exactly what you want to do there, right? Okay, so I'm going to wrap it up for the moment and see if we have any questions that have come in and devote the rest of the time towards your questions, okay?